And I'll just give a very brief introduction of myself as the moderator, and then we can jump into some questions. So again, I'm Rebecca Anastaswallen, she, her pronouns. I'm a medical director of population health and clinical services at Oak Street Health, a general internal medicine doctor by training, and spent a long time in the business world, 5 years before I went down the medical road. So I've been interested in LGBTQ health really since undergraduate, and have been involved in organizations promoting this throughout my time in business, in medical school, and medical training. At Oak Street Health, I spend half my time seeing Medicare patients in our West Philadelphia community, and I'm also helping lead some of our national programs focused on improving the quality of the care that we provide for our patients. And with that, I think we can jump in. So I was hoping that we could start the discussion with a focus on some of the specific chronic conditions that the aging LGBT population faces, with some focus on how virtual care could specifically help to improve the quality of care for these patients. Things that come to mind, for example, are increased rates of neurocognitive disorders in patients with HIV, higher likelihoods of smoking, less access to, or LGBT patients are less likely to have received necessary preventative screenings, that type of thing. Feel free to jump in, anyone.
I can jump in first. I guess with regards to HIV care, I think a lot of us are concerned about the effects the pandemic has had, just in terms of people maintaining care with their providers and the difficulty they've had. I think one thing I see as I also see patients at Oak Street, so I spend about 70% of my time doing clinical work here. So I picked up a few patients who are still seeing ID physicians for their antiretrovirals, and I basically have to let them know I do HIV care myself. You don't need to be seeing a specialist. And I think that's part of it too, is like helping to train up just a wider pool of primary care providers and taking care of folks with HIV so that they don't fall through the gaps, because a lot of the concerns in terms of cardiovascular and neurologic disease can really be mitigated or almost totally eliminated if you've got someone on effective antiretroviral therapy and their viral loads are suppressed and their CD4 counts are at target.
Yeah, I think the issue of HIV specifically is very interesting, because my experience is many of our elder patients living with HIV have been doing so for a very long time. And they were the people who started off taking monotherapy and dual therapy. So their bodies have gone through cycles of much more toxic drugs than we use today. And so I think the neurocognitive impact of that is, even more than it will be in the future when someone may have been on antiretrovirals for a long time, because the newer drugs are just so much less toxic. And one other thought I want to add to the discussion, I've seen so many people, COVID specifically was like a flashback to the 1980s. There's this new virus, and people don't really know what it's doing, and the government is not seeming to respond as quickly as it. And I think it was very triggering for a lot of people who lived through that in the 80s and lost many, many friends and lovers and partners. I saw many people really suffer psychologically when COVID unfolded itself.
I would concur with that. I know that I'm a member of the GLMA, and last year's GLMA meeting, we had a discussion specifically talking about the intersection of COVID care and just LGBTQIA plus care. But I think a lot of people felt that I started taking care of folks with HIV in the early 90s when we did not have miracle drugs. And I concur with you also about some of these folks who are older, unfortunately, have had a lot of the metabolic issues and such from, basically going through the successive generations of treatment. But again, I think a lot of folks, unfortunately, were cut off from their support networks, from their families of choice during the pandemic. And again, I think it really was triggering because, again, I think those of us who, were activists during that time, just, I guess they say history doesn't repeat, but it rhymes. And it was sad to see that it feels like in many respects when COVID came out again, that it appeared like we had learned nothing from HIV and from really that hard fought experience that people had. And that we really had to re-educate the general public in saying you need to take pandemics seriously. I think we're seeing this again with monkeypox, where a lot of epidemiologists are fearing that monkeypox has already gotten to the extent that we won't be able to contain it just with standard public health measures like contact tracing, because again, we were not aggressive enough out of the gate.
Mentioning that the stigma piece of
Yes.
COVID, I think for so many LGBT folks, it sort of re-exacerbated the stigma they felt during HIV. Like walking down the street and having people walk on the other side of the street and always, keeping 6 feet apart. It really was incredibly triggering for so many folks.
Yeah, and then again, I think now, especially with monkeypox as well, since it is disproportionately affecting men who have sex with men, that again, that is another additional source of stigma. And I think that unfortunately stigma, not only is isolating, but it also gets in the way of basically harm reduction and just sensible public health policy in terms of how can we get everyone at the table who needs to basically work on combating multiple just health issues and pandemics at the same time.
Right.
And then the stigma.
Another thing.
I was going to say, and then the stigma affects access to care and people being reluctant to go into care. Absolutely. Sorry, Peter.
No, I was going to really adding to that. Rebecca, you mentioned screenings and the likelihood or not for people. I put it to the panel and the audience. You don't see any promotional health information about, say, hypertension that features same-sex couples or a transgender person, and it is absolutely not that if you're LGBT you don't have that. You're not going to get hypertension, but if people don't see themselves reflected in these outreach campaigns, they are not going to respond to them. And it's actually one thing I did want to at some point talk about, so I might as well now. One of the things that has been so successful at Callan Lord is we've done these photo shoots where we offer our patients and our staff the opportunity to get a headshot done professionally in these photo shoot days, and they're fun headshots. They're not like boring ones. They're you're encouraged to dress up or be your true self, and then the patient gets a great set of headshots they can use for themselves, and they sign a waiver allowing us to use those in our promotional materials, so that now we do have things that are about just bread and butter healthcare, diabetes, asthma, hypertension, but featuring people that reflect the community we serve. And it's been really, really powerful and has received a lot of positive feedback. But I think, so often the LGBT community is just left out of public health interventions unless it is about HIV or monkeypox or something that's very sort of specific. So I think there's a lot of work to be done there.
Yeah, I love that. I think that's definitely something I hear from my patients is missing, and the stigma even just to come into a doctor's office, especially when it's not a place like Callan Lord, remains high. I'm interested in what you all think about, in addition to ideas like the one Dr. Mitra just shared. What are some other steps that we can take to try and help our patients with chronic conditions more, either locally, like you're doing at Cal and Lord, or perhaps in places that are where the stigma may be even worse, and there are less protections legally, but we may have some reach virtually, for example.
I think.
I mean,
Oh, I'm sorry. Get in on you, Peter. I think from the very beginning, we have to remember LGBTQ plus elders' history of discrimination, right? You have to acknowledge that that was so incredibly pivotal and so much of the experience that so many LGBT elders have experienced, being arrested, being fired, and even worse, right? The experience that they have experienced has had horrible impacts on their health and on how they access social services. We know that LGBT older adults actually are hesitant accessing social services, right? They're missing out of meal programs. They're missing out of connection to social services. And, and consequently, they're missing out of connections to case management and people who will assist them in getting needed benefits and helping them access care, right?
Yeah. And I would say like at Oak Street, like in contrast to if you're working at health centers that are, LGBT specific from the get-go, I think when people come to a place like a Cal and Lord, or say here in Chicago, Howard Brown, or the Mazzoni Center in Philly, that they already have an expectation that folks will, basically be savvy about LGBTQIA plus healthcare issues, whereas at some place like Oak Street, there's no such expectation. I think that that's something that we're working on, is trying to get people more comfortable with that. And I feel, and Rebecca, I don't know if this is your observation too, is that I think we tend to be more neutral in terms of not like having a lot of the representational stuff in our promo materials in terms of, so I think we need to come at it in another way. And I think one thing that I've started to work on is just really getting people comfortable with even asking the question in the first place, like getting that sexual orientation and gender identity information. And I think one thing that interestingly has come up as we're starting to do this work is that because Oak Street is in, I guess, in some areas where I guess people are, I guess what you characterize as more conservative, like, for example, like in the, in the Plain States or in the South, that I think that there are providers who are sometimes a bit hesitant to even open up that conversation about sexual orientation and gender identity, because I think that they're afraid that even discussing those things has become politicized. And a key thing that I've been trying to emphasize to folks is that our patients are waiting for us to ask those questions. I mean, they in surveys, 70% of patients want their provider or their healthcare professionals to be the ones to initiate the discussion. And I think we also have to emphasize to providers, because again, there aren't enough LGBTQIA plus healthcare providers to take care of all of the LGBTQIA plus patients that are out there. So we really need to have allies and make sure that other people feel comfortable doing this work. That it also that the patient, you have to emphasize that they're in a protected space. What's in the exam room stays there, but that we really need to have a holistic sense of your health in order to take care of you, and that we need to ask the questions because we can't make assumptions about who you are just based on how you present.
Yeah, that's a really great point. I think that's an opportunity we as Oak Street have, because we have that national reach and we're in places like, New York and Philadelphia, but also more rural places that are traditionally less accepting. I think it's also something that, we don't know where our participants are on the call, but hopefully if there are any participants listening from states that are less accepting, it's, something that a message we can spread in terms of just making it routine to ask these kinds of questions. We've talked about the intersectionality as it relates to some chronic conditions that the LGBTQ population faces. I was hoping we could spend a little bit of time on some of the social drivers that may be impacting this as well. whether there are cultural issues, other social determinants of health that may be driving disparities in health outcomes, access to care for the LGBTQ community.
I think David hit on some points in terms of remembering people's past experience and how that has impacted their life, and the fact that they are entering the later years, they will have lived through an era unlike today and hopefully unlike our future. But they will be carrying all of that experience with them. And so I think that is a huge, even if someone is in an environment that currently is much more progressive, even in that situation, they have the baggage of all those years of experience that will have had an impact. You know, here in New York, I've had discussions with patients who either their loved one or someone they know is, you know, going into assisted living, and the sort of accepted wisdom is used to go back in the closet, you know, at the end, because it's just better to not be out. And it's very hard for me to imagine making that decision. But if the environment feels that that is the safer thing to do, that's what you're going to do. So I can imagine it's, you know, 10 times more intense in states that are less progressive in their policies.
Yeah, and I concur with that. I think a lot of our LGBTQIA plus patients are at a disadvantage. I think it's the Williams Institute out of UCLA that says that, you know, like, contrary to popular belief, I think a lot of the stereotype is that, you know, because LGBTQIA plus individuals are less likely to have like families and such, the stereotype is the double income, no kids, but that's not the reality of how people live their lives. And also that a lot of people just have not had access to the same economic benefits as, you know, their heterosexual counterparts, that because of either real or perceived discrimination, they just haven't been able to get as far in terms of careers, economically, have saved as much. So I think we have a lot of work to do to make sure that, you know, like, their, you know, basic hierarchy of human needs are being met first, you know, before addressing their healthcare issues. So I think we have to be more cognizant of that with our LGBTQIA plus patients, maybe more than some of our other seniors that we take care of.
Yeah, I think that the loneliness and isolation is so incredibly significant for people as they come into exam rooms. They're half likely to be partnered, twice likely to live alone. They're just disconnected, and that type of social isolation has horrible, horrible outcomes for many folks.
We had a really remarkable experience when the COVID vaccinations started to become available, and we were able to dispense them. Because initially in New York State, it was an age-based criteria for eligibility. And so we were having vaccine-only sessions for people over 60, or, you know, and they were all came in. And it was the most wonderful, wonderful experience, because what we realized is that Callan Lord, being over 65, you're definitely in the minority. And most of your experience coming to the health center is you are the oldest person in the waiting room, and, you know, maybe you see someone else your age or maybe not. And so that is perhaps makes you feel even more sort of isolated. In this case, people were just whooping it up in the waiting room and reconnecting, and it was such a joyful experience just to see people, especially after, you know, a year and a half of COVID, they were suddenly having some interactions with peers, and it was a really remarkable experience, and it's actually lent us to be thinking about, designating a specific day of the week where we mostly try to schedule our older patients. Not that they would be not able to come other days, but just to have that sort of sense of community that people so crave and would so transform the health center. And it was actually a model when I was working in the South Bronx and in a not an LGBT center, but I started to have quite an LGBT following, and we started to schedule people who identified as LGBT on a certain day of the week, and it achieved the same thing. It allowed just the environment of care to feel like it was a home for you. You were looking at people around you who you identified with and had shared experience with. So I think that's an interesting strategy to think about, even when, especially when you have a group that is maybe not a majority, but a smaller part of who you take care of.
Yeah, that really resonates. I've definitely seen the increase in social isolation that came with COVID seem compounded for my LGBTQ older patients. And honestly, as a clinician, have been struggling to try and help them make connections, especially when a lot of the community resources are still all virtual. And it's just harder to engage. So as an older person. We've talked about some of the ways that that healthcare providers can advocate and support older LGBTQ adults. I'm wondering what the group thinks about ways that we can play a role in educating non-healthcare providers to advocate for and support this community.
Well, I guess one thing that I found useful just throughout my career is just like really looking at starting change from the top down as well as from the bottom up. So during the time that I've been involved with GLMA and with, I guess, HRC, with, basically their healthcare quality index survey, it's amazing how when you start to implement tools like that, that really changes the environment, that it gets people who are like not directly involved with LGBTQIA plus health, thinking about what they could be doing better to serve the needs of the LGBTQIA plus population. And, and to be crass about it from a business perspective, starting to think of LGBTQIA plus patients as a market that they need to actually cater to and serve. So I think that that's one way of getting sort of larger change within healthcare, even for people who aren't like directly, clinicians or directly involved in patient care. And also like working with, national standard setting organizations. So when I was at Illinois Masonic, the Joint Commission actually came, and I was surprised that, they actually reached out to us directly because they noticed that the hospital I was working at was had implemented a lot of innovations in terms of LGBTQIA plus friendly healthcare, and they wanted to learn from us and from other similar organizations so they could actually put together a document, which ended up being their field guide to LGBTQIA plus healthcare. And getting a huge organization like Joint Commission involved is huge because literally they have worldwide reach. So it's neat to think that like getting Joint Commission to agree that you need to serve LGBTQIA plus people equally and here are the service standards, that doesn't have an effect just in the US, but it could even have an effect in, say, a Joint Commission accredited institution in, say, Saudi Arabia, which is like probably one of the least friendly LGBTQIA plus countries on the planet. That speaks to how, that's how we can get people thinking and like really giving them a nudge or even a shove in the direction of doing the right thing.
I think from the social service standpoint, You know, the last administration was extremely challenging for many LGBT providers throughout the country. However, we did have a significant win in the last administration, and that was with the Older Adults Act, Older Americans Adult Act, which is the act that funds senior programs throughout the country. We're actually able to get LGBT older adults listed as a special population. And that means that now they have an identity and that they're visible. And funders and agencies throughout the country need to now include LGBT older adults in their outreach plan and in their marketing efforts. And that's an important step for LGBT elders to begin to feel included in and visible within agencies throughout the country.
And David, I think that also speaks to just a wider push by, I'd say, LGBTQIA plus health activists in terms of getting us included in like HHS's research agenda through documents like the Healthy People, like I guess it's now Healthy People, I guess 2020 right now that we're currently working off of, so that, you know, they really need to be collecting research, just like if you're going to apply for a federal grant, that you need to also, you know, do your demographics in terms of which of your research subjects identifies LGBTQIA+, so that we can really break out the specific needs of our populations. And that helps us in terms of where can we do more advocacy. And I think, you know, even though that's something that I guess is maybe not like directly connected to the work that we do as primary care docs, we do need people working in like healthcare services research and such. And we need to build that infrastructure to identify not just present needs, but also future needs.
What are the best avenues that you've found to do that? Other than, it sounds like some happenstance has been helpful, but I'm wondering what some of the other strategies anyone on the panel has used.
Well, I think just speaking for myself, you know, whenever I join a new organization, I think one of the first questions I ask is like, what are you guys doing in terms of LGBTQI health? Because I've really worked most of my career in, you know, non-LGBTQI health specific healthcare organizations, such as like safety net institutions or public health departments. So, but I think it's just, you know, what are you doing, and like looking for who the people are who have interest in this work and who your allies are.
And I think there are big picture things and there are small picture things, and they're all effective. I think of a small picture thing that I've been involved in for years is a clinical care committee we have at Callan Lord, where we every quarter meet as a group. This is a group of people involved in healthcare around the city from different institutions, all different professions. And we share what we're doing at Callan Lord around quality of care. And I know from having been on that committee before I worked here, that I would take information back to my institution and integrate it into some of the work going on there. So I like to think that this type of action, where we're really building bridges, building partners on a sort of micro level, can have enormous impact on a macro level. And then, you know, we do a lot of advocacy as well on the state level, especially, but sometimes federally. So we actually have an advocacy department, and we take our clinical staff to many of these meetings, and it is extraordinary, having done it for years, how impactful it can be if you're in a senator's office. And I mean, you can, it's actually the stories that hook people in. You know, if you can tell as a clinician, talk about a patient you saw and an experience they had, that I think so often has, it's just, I have a feeling the political person remembers that story more than they'll remember graphs and tables and data, but they'll remember the story. And so I think we who are working in clinical roles, we need to understand that actually we shouldn't be leaving the advocacy to other people. We need to be doing it as well, because our voice is enormously powerful. And it's a real, it's very rewarding when you realize that.
I would definitely underscore the partnership piece. There are tremendous opportunities for strategic partnerships and really being mindful about including agencies and grassroots agencies and really particularly agencies that serve BIPOC communities and trans communities, and making sure that they have a seat at the table and a voice in developing these strategic partnerships so care can be delivered in an intentional and mindful and strategic way.
Thanks, all. I really appreciate that perspective. We're going to open it up to questions in a few minutes. If anyone in the audience wants to start putting questions in the chat, you can go ahead and do that. I'll monitor those and can raise them. While we wait for some questions to come in, I had one last question, which is a little bit of a pivot, which is specifically around the role that virtual care can play in addressing some of the barriers that we've discussed today for older LGBTQ adults. Dr. Sackleton and I both use the Rubicon MD platform a significant amount in our own daily work to provide better patient care. And I know Dr. Meacher, you use it as well, and are also one of the specialists on the platform. So I'm interested in hearing more about that component of this.
Yeah, I'd love to speak to virtual health first. You know, I think with every disruption there comes enormous opportunity, and none more so than with COVID. You know, we were vaguely sort of maybe thinking about somehow getting to a place where we could do video visits in the next 5 years. And then COVID happened, and suddenly, like within a couple of weeks, we were doing them. And so it has allowed us now. I'm very determined to keep a virtual component to the care that we do, and you know, underscoring the obvious, like this can never be the only way you offer care to patients. It's not going to work for some patients, but some patients are not going to have Wi-Fi, the hardware, the tools, the interest. But for some patients, this is an enormously positive move. You know, we have patients who travel 4 or 5 hours each way to come to Cala Nord for care because they can't get the care they're seeking where they live. And now, if we can do some of those visits by video, you know, you're giving so much, you're just creating so much more access for patients. And more than that, I often talk about when I lived in Australia, I used to do a lot of house calls as part of practice. And I see the video visit and the dynamic of when you see a patient in their home is just so different than when you see them in the office. You get to understand what's going on so much more. It's a much more sort of level interaction. It's not as hierarchical as the provider and the patient is in the office. And there's something about the video visit that feels halfway between those two. You know, I love seeing people's pets, meeting their partners or family, asking to look, okay, let's take a look in your fridge. You know, you can have them actually not just tell you what they're eating, but okay, showtime, what's in your fridge? So there's so much, I think, potential for this to be a really positive, useful tool. So I'm really excited about using
it. And I think in terms of e-consult specifically, that it's just a real time saver in terms of how we integrate into our workflows here in Oak Street. That now we've gotten to the point where we can actually place e-consults directly, either our providers or our scribes, and they can actually get incorporated into our EMR. And I know one thing that our LGBTQIA plus DE&I committee has been talking up is that for those folks, especially folks who, basically live outside of like centers where they could maybe call somebody locally who's an expert in LGBTQIA plus health, that they can actually consult people on Rubicon who, maybe an endocrinologist who can advise about, gender affirming hormone therapy, or just in terms of just more general questions regarding HIV care, et cetera, that they now have access to that expertise. Whereas before, I think if say you were in a place like in Oklahoma or Texas and you weren't near an urban center, you'd probably be hard pressed to get really good evidence-based care at your fingertips. So, and I know it's having served sort of like as a local expert here in Chicago, just for folks who have questions about hormone therapy or such, that I'm glad that we have more access for more providers through e-consults, and I think that that's one of the few silver linings. I agree with you, Peter, about COVID, is that this genie is now finally out of the bottle, and hopefully there's no going back, and that we can further leverage and amplify, so that people have more access to expertise, because it's really empowering, not just for the providers, but for the patients.
Yeah, and I think it strengthens, just from my own experience, it really strengthens the relationship that we as primary care providers have with our own patients, because we can provide care to them in a way that is affirming of their identity, however they identify, and lets us do that directly without having to necessarily sort of reach out to a specialist who may or may not be available in our local area, or might have a very long wait time. So one audience question, just a couple audience questions just came in. The first is, are there some key organizations you think providers can be partnering with?
Well, I think we have a panelist from one of those organizations here, which would be David. So certainly SAGE is, I think, a key organization. I know here in Chicago, our local AARP chapter here, apparently they just did a survey of the LGBTQIA plus health community in terms of what their needs are. And I've just been trying to work with our local AARP representatives to get a hold of that survey to see how we can leverage that to provide better healthcare for LGBTQIA plus our patients here in at Oak Street in the Chicago area. And I suspect that organizations like SAGE and AARP are probably doing that work, but they're probably also looking for healthcare partners, because that you can do a survey, but in order for that survey to really have effect, you need to have other people who can help put those findings into action.
David, are there specific ways that you think that providers could partner with SAGE to access resources for their patients, or get education, that type of thing?
Yeah, absolutely. We have a National Resource Center, which serves as a tremendous resource for folks. I will put the link in the chat for us.
Great.
Yeah.
Another question. Go ahead.
Oh, sorry. So in terms of key organizations, I think that for providers, they're basically their professional organizations also have resources for LGBTQIA plus care, like the American Association of Family Practice, the American College of Physicians, our nurse practitioner organizations, PA organizations. They all have LGBTQIA plus interest groups, and those are not just open to LGBTQIA plus identified providers, but also allies. So I think that that is another organization that providers can partner with. And then a couple of other organizations off the top of my head that I think could help. GLMA, which is the largest organization for folks who take care of LGBTQIA plus patients. They do have a great list of resources, including like questions that patients should be asking their providers, plus ways to make your health, your organization more LGBTQIA plus friendly, like your office or your clinic. And then PFLAGs, Parents and Friends and Gays and Lesbians, they actually have resources also to help allies and such in terms of how can you be better advocates for the health, basically for the health needs of LGBTQIA plus persons, and how can you make the the healthcare settings that you interface with more LGBTQIA plus friendly? Because again, it's not just enough for our patients that they have good experiences at our health centers, but they're also going to be going to hospitals, other specialist offices, and we need to make sure that they have good experiences there too, because unfortunately, like as David and Peter said, like a lot of our patients have not had good interactions with the healthcare system, and it can take just one bad interaction to have, that would, basically trigger them and make them disengage again, and we want to avoid that.
They're really great points. We have time, I think, for one more question, so I'll read it out and then we can wrap up. The question is, have you had experience with patients coming out late in life or having to go back in the closet and then come out again? And if so, any recommendations for supporting them?
I personally have not had that experience. I think I try to get patients basically to seek out all their options to find someplace that is LGBTQIA plus friendly. But unfortunately, I know in the Chicago suburbs, we did have one, instance of a woman who actually, she did not go back into the closet and was harassed at her long-term healthcare facility. And I think there was a major lawsuit that came out of that. So it does happen. I think at least in most urban centers, at least there are larger numbers of like senior buildings and long-term care facilities that are LGBTQIA plus friendly. But but definitely, that is going to be an issue for patients elsewhere.
I think from a provider standpoint, helping to ensure safety is an important piece. So when folks receive home care, for instance, working with the home care agencies to ensure that there's a level of LGBT competence for the staff that they're sending out is really important. And I think providers can play a key role in having those important discussions with the home care agencies and the administrators to ensure that their patients are going to be safe and going to be treated with the utmost of respect when they're receiving care at their home.
Yeah, and I would say at the end of the day, it's not for us to decide what is right for patients to do or not. It's for us to support them and in their decision making. So, if a patient does decide that they are going to go back in the closet, I certainly would never spend my time trying to persuade them not to, because I actually don't know. They might be making a very important decision. So I think our role is really to support people in their decision making and avail them of information as best we can, whether it is about alternative options that might not require them to make that decision, or what their rights are, but never to sort of tell someone you shouldn't do that. So I think that, is most people who have been in clinical practice, and I'm sure everyone on the panel, would never would approach any issue that a patient brings you with a sort of joint decision making.
Any thoughts on those patients who have come out later in life specifically? I don't know if SAGE has any specific programming for patients who have come out later in life, or anyone else has experiences with that.
Well, all of our program is for people who are out in later in life, and we have many bits of program for people who aren't out, right? So we offer a number of virtual programming for opportunities for folks who want to participate in virtual programming. And a number of folks who participate in our virtual programming are people who aren't out. They aren't out and they don't feel safe sort of coming out to an LGBT identified location, or don't feel safe being a person of trans experience riding the subway or walking down the street as a person of trans experience. So providing virtual programming is a tremendous opportunity for those folks, and ensuring they're getting the social support and the community that they so desperately need.
And I think it's important if, say, the only place they feel they can be out is, say, with you or with your group of healthcare providers at the facility they get care from, just at least ensuring that they have that connection at least. At least they can be uncloseted while they're with us.
Well, we are nearly at time. Any final thoughts before we wrap up, everyone? Anyone?
Well, I think it's just the bringing these two areas of focus together is just such an opportunity to improve the care we offer for LGBT people who are aging, which is everyone. Well, everyone's aging. So, you know, I think we have much to learn from each other, and just thank everyone for starting this discussion.
Great. Thanks,
Yeah,
everyone.
I'm sorry. I had one more thought. My husband and I just started watching this. It's a series. I don't know if it's a web series on PBS called Pride Land, and the person who's basically heading it up, I guess he's from the South, and he pointed out that like basically 1/3 of all LGBTQIA plus identified adults live in the South. So the South actually has the highest concentration of LGBTQIA plus individuals. So I think it's important to remember that, you know, the folks that, you know, really need the access, a lot of them are in places that are not friendly, but I guess part of the series is showing how they're resilient and how they're fighting back. And so I think it's, you know, it's sort of like almost like sort of our more moral responsibility to make sure that those folks are also supported, and that, you know, and that we make sure that they have the resources that they need. And I think a lot of these electronic resources are great for that, in terms of getting resources to areas that historically have not gotten that representation in those resources.
Awesome. Well, I wanted to also just quickly say thank you so much to all the panelists. It's been such an incredible discussion. I know we all have a ton of takeaways. So thank you everyone for joining as well on the attendance side. And I hope we can have another event similar to this. So thank you again.